So hi Kavita,
Hi, Srivatsa. How are you?
I'm fine. So it's so great to be sitting across the screen, talking to you. It's been quite some time since we both saw each other, and perhaps many years since we met. And
I know.
Viewers, let me introduce Kavita. So Kavita has always been a bright star throughout college years, and I was lucky to do undergraduation with her at Bangalore. Subsequently, Kavita went on to do internal medicine residency and pulmonology at Yale New Haven Health at Bridgeport Hospital, followed by which she completed her critical care medicine fellowship at the Mayo Clinic, Rochester. And perhaps she is the most ideal candidate I would be interviewing with regards to this topic. She will be sharing more information with us regarding SARS CoV-2 infection, and she's going to give us a brief overview of certain important points that's going to take us a long way in managing these 5% of patients that are really sick and go into the ICU. And little did we know, Kavita, that we would be stuck in the same boat many years later. And I'm so excited to be doing this with you today. Okay, so
Thank you so much, Srivatsa, for this opportunity. This is such an exciting time to be in medicine, but at the same time, a very sad and humbling time because I don't think any of us ever anticipated being in the middle of a pandemic, let alone, being in the same specialty and the same field and seeing you across thousands of miles on a video conversation. So I'd like to get started by just going over a few learning objectives for this presentation. So what we'll look at is a little bit of a background on what COVID-19 is all about. A brief overview of virology and the modes of transmission, which would become very important for caregivers like us. An examination of the clinical symptoms and what are the testing approaches that we have been using. And obviously, a lot of recommendations have come through with various guidelines from the SCCM, CHEST, and ATS. Evaluation of treatment approaches, and that would mainly involve ICU strategies for managing these critically ill patients that we take care of.
okay, so I think that covers most of it. So could I ask you the first question? So the first question for today is, what is the epidemiology of COVID-19 and what are you really seeing at the ICUs at ground zero?
Absolutely. So COVID-19 is also known as SARS CoV-2 or the novel coronavirus 19. And it's named so because it started off in 2019, which was when it was first recognized in December 8th in Wuhan. And as everybody very well knows, and you've been watching the news, by January, there were many more cases. Mostly in that time period, it was still reported in China. And in early January, a viral pathogen was actually identified. Subsequently, as the months progressed, from January to about March, there were human-to-human transmission, and the first case in the United States was reported on January 21st. However, ever since then, as everybody really knows now, 6 million plus cases have been noted throughout the world. US has about 1,800,000 cases or so, and India is quite quickly catching up, becoming one of the top 10 countries of reported cases with 191,000 cases so far. And this data is mainly from the Johns Hopkins University's educational map that they have real-time updates on cases as they're going through. So a brief look at what actually coronavirus is, and it is named so because it has a crown-like appearance with the spike proteins that surround the outer membrane. It has a membrane which is essential for the viral assembly, and a nucleocapsid protein which regulates the RNA synthesis of this virus itself. What exactly happens when this virus was first detected? It can be taken back to the time when SARS and MERS were also detected in the same coronavirus family. And SARS stands for Severe Acute Respiratory Syndrome, and MERS stands for the Middle East Respiratory Syndrome virus. And these were transmitted from a cat species as well as camels from the MERS, and armadillos, which were actually the zoonotic hosts, and then that led to a spillover into the human population. And the main mode of transmission from an infected human being who becomes a host for the zoonotic virus is that when the infected individual coughs and produces more droplets, which are greater than 5 microns in size, and it travels about 1 meter distance or so, and that gets in onto surfaces which are contacted by fomite sort of transmission by touching these surfaces, as well as direct droplet transmission to a susceptible individual. So precautions need to be taken for both droplet as well as airborne modes of transmission. The disease in humans actually is clinically characterized by fever, cough, sputum production, and shortness of breath, which have been identified as the predominant presenting symptoms that are noted. So for caregivers like us, this is something that we would often have to keep a watch out for, raising a suspicion for the existence of this disease. An incubation period varies anywhere from 4 to 7 days, but a median time of about 4 days. And this is all data obtained from Guan and his team, which was published in the New England Journal in March of 2020. And obviously cases have been evolving with also presentation with GI symptoms such as nausea and vomiting, and if infrequently noted to have diarrhea as well.
I
It
hear
is
that most of these cases have persistent fever for a long time. Is that true? That most of these,
correct.
we do
So
see a lot of cases that have been having fever for almost past a week or more than 10 days.
very true. And that is something that we are noticing here as well within the United States, amongst a lot of cases that we are caring for, where they have, even though their incubation period is about 4 to 7 days before presentation of symptoms, their fever curve often doesn't resolve up to a period of almost 2 to 3 weeks later, where we still see presentation of low-grade fevers ranging between 38 to 38.5 degrees Celsius. And that's something that helps us keep track of probably how much viral shedding or viral load that these patients have had. And other things that we often look out for are laboratory abnormalities. And the key things that we want to highlight is the presence of lymphopenia, which is noted in about 63% of patients. Leukocytosis is variable, leukopenia is variable. However, liver function tests, elevations of AST and ALT, as well as LDH is actually quite often seen. Other values such as elevated ESR and CRP, which give us an indicator of how severe the inflammatory process is within an infected individual, is also very key for monitoring and tracking the progression of this disease across its duration of illness, which can range from a mild symptomatic person which
So
lasts about
is
4 to 7 days,
CRP
all the way up
valuable
to
in basically, tracking the infection? Is
sorry,
CRP
say that
valuable?
again.
Is CRP valuable in basically tracking the infection through the course?
Yes. So also CRP, one is it's useful in tracking the severity of inflammation and and also looking at the progression of it. Not that resolution of CRP is a true indicator of complete resolution of the disease, but also CRP and ESR as well as LDH are playing a key role in monitoring for effects of medications that are now being trialed to actually treat the disease. So that plays an important role. And one of the things that's been highlighted across thousands of cases now that we have seen with coronavirus infections is the coagulation abnormalities that are noted, and using a D-dimer to assess as an initial evaluation blood test is very helpful as well. And we'll review that in some upcoming slides. Interestingly, as we've known procalcitonin to be a marker of profound infection, especially bacterial infections, given that this is a viral infection, is normal in most cases. Imaging findings, although this has been also hugely variable depending on the spectrum of disease, whether you fall within a mild disease category versus a severe disease, which is potentially towards full-blown ARDS, is noted. So as you can see, the first image here up on the left of the screen shows some increased markings in and sort of vascular prominence of possible right middle lobe infiltrate, but otherwise largely unremarkable. Whereas in contrast to the image on the right of the screen, where you see diffuse bilateral alveolar opacities and airspace opacities, some denser areas of consolidation bordering the subpleural areas. And this has sort of been the huge spectrum of this disease, which is why it's also very difficult to find clear radiographic evidence to say, okay, this is very specific for COVID. Continuing the same theme, when you look at imaging findings from a CT scan, you tend to see patchy bilateral ground glass opacities. I tried to put these in a progression of number of days, so going in a clockwise manner. So the top left of the screen is a very initial early CT scan finding, and these are studies from radiographic images obtained in China. And so you can see very small amount of ground glass, and then it progresses by 10 days to involve slightly larger areas of the pulmonary parenchyma. And then by 17 days, you start to see more significant subpleural areas with the arrows that are pointing to areas of pleural thickening, as well as slightly more consolidative sort of changes that are going on towards the 20 days mark. So you can see that more
organizing pneumonia pattern, you call, or
it does look like an organizing pneumonia pattern.
This? I mean, do we really see pleural effusions quite so often in these patients?
Very, very rarely. And so given that these findings are so non-specific and they are lower lobe predominant, but if you have an area of consolidation definitely preceding that, you would have had GGOs if they had actually had imaging. And Srivatsa, you bring up a great point, which is what I'm going to highlight in this slide. What are the things that are absent in a radiographic imaging from a COVID standpoint? This becomes very important to know, given that the findings are non-specific. If you know what's absent, you can probably rule out a certain number of patients that are dealing with this disease. So absence of lymphadenopathy, there is absence of a true lung mass. So if you have a very well demarcated spiculated nodule or like evidence of metastatic disease with very well demarcated lesions, it most likely is not COVID. Cavitation is very, very rare and almost not described in variable radiographic series that have come out of China so far. Pleural effusions, like you very well mentioned, are rare. But evidence of pleural thickening has been consistently described in most of the radiographic findings. And subpleural origin with central sparing has sort of been the pattern that is more often noted. Another very important topic to discuss, given our field of expertise is within imaging also on the pulmonary side of things, is what about the utilization of lung ultrasound? We do this on a regular basis to evaluate patients for evidence of pneumothorax, evidence of pleural effusions.
So would you consider frequent, ultrasound over, frequent X-rays in your patients at the ICU? Is this a very
So frequent ultrasounds are probably more helpful, not only from the standpoint of lung ultrasound, but also from the standpoint of a critical care evaluation of a cardiac situation. So more frequently monitoring for evidence of sudden depression of EF or worsening RV dysfunction, which also in severely ill ARDS patients is already known to exist at about 35 to 40% of cases. And there's a lot of overlap between that. But what I wanted to highlight with this slide from a lung ultrasound standpoint very specifically was the variability of the findings. So it can range all the way from simple B lines, which is seen in simple pulmonary edema just from a volume overload standpoint, all the way up to finding a very large area of consolidation from an ultrasound. So if you're going to utilize this as a diagnostic modality or a modality for tracking the progression of disease in a patient that you're caring for, having a very organized methodological approach to the ultrasound itself and not just scanning 4 areas, like we normally do 2 on the anterior chest and 2 mid-axillary regions. Having a very organized way of going through each and every rib space, again, becomes very cumbersome. But if you have the time and the luxury of caring for only a few patients at a time, this probably becomes useful. So you see a variability of presentations, right from simple B lines to confluent B lines like a waterfall sign, from small subpleural consolidations as highlighted in the very top area of image C, all the way up to larger consolidation patterns, which can very well be detected on an X-ray. One interesting finding that we have been dealing with within our ICU is we have been trying to stay away from getting routine daily chest X-rays, which in a non-infectious situation of severe ARDS would be very useful. We would look at ET tube position, line positioning, as well as what are the pulmonary findings on a day-to-day basis. But the risk of exposure to our X-ray techs, as well as the nurses, and breaking an airborne room's seal every single day, if you need it, is a little bit more risky, and hence we're staying away from daily chest X-rays. I hope that was helpful.
Of course. So
one of the other things that has been interesting is looking at the progression of CT abnormalities in patients with COVID infection. So a lot of times early on, if you choose to image. So this is where the history is very important of what duration of symptoms have they had. So if you're very early on, you're trying to get some imaging, then probably stay away from CT because you're really going to have a large amount of them having a normal CT scan. However, as time progresses, by getting to about 6 to 12 days of duration, you start to see these peripheral ground glass opacities, as we saw in the previous slide. So your imaging modality of choice, also based on the duration of symptoms, can be tailored, again, with the same goal of minimizing the exposure to the providers and the technicians who are putting these patients through a process. And again, same way, avoiding breaking a seal. And if you are going to send them through a CT scanner in a high volume center, and if they're not on a closed circuit mechanical ventilation and they're just on nasal cannula, putting a patient on a mask and avoiding aerosolization or having them cough within a CT scanner is very important. Again, having very standardized methods of deinfection of all these instruments also plays a very key role in reducing transmission within a healthcare facility.
So there's an interesting question that comes up. Most of these radiology societies publishing guidelines on using CT scan as a screening modality for COVID-19. And we ourselves at our unit have seen that sometimes when the COVID test is negative, the swab, for whatever thing that goes faulty, if the swab is negative, the CT scan becomes a better tool to assess these patients to determine whether they really have COVID-19 or not. So what's your thought on that?
That's a wonderful point that you bring up, and a lot of times that we have seen this time and again here as well. So one of the things that we are utilizing in terms of preventing transmission, even if a patient's COVID-19 swab is negative, is that we are using universal precautions with all comers into the hospital. The second thing is trying to diagnose COVID-19 by just a CT scan imaging perspective becomes very difficult because of its non-specific imaging findings. And it's a very generalized sort of imaging finding that you're seeing. You see the same patterns emerge in a lot of interstitial lung diseases. For example, you can see it, like you said earlier, it can present in a organizing pneumonia-like pattern. It can present anywhere from pulmonary fibrosis-like pattern if it has been ongoing long enough. And just to simple ground glass opacities, wherein the differential, as you very well know, ranges from viral pneumonias to inflammatory processes to a lot of rheumatologic processes with coexisting ILD can come in with. So the key thing in those situations is to have an imaging modality that raises a high suspicion combined with another testing process like whether it's a repeat nasopharyngeal swabs, or whether you're trying to get a deeper respiratory sample specimen. And I will be reviewing that in my upcoming slides. So I'd like to switch gears here just to highlight the importance of understanding how wide and varied the spectrum of COVID-19 infections is. It ranges all the way from having multi-organ dysfunction with septic shock to ARDS predominating this clinical picture and the need for invasive mechanical ventilation. Early recognition of risk factors is very key in identifying who are at more risk for developing this disease, and therefore isolating them could prevent further transmission as well. So males more than females seem to be more infected, age greater than 65, smokers and chronic lung infections. Other pre-existing conditions such as diabetes has been shown to be a significant risk factor for developing this disease. And most importantly, not to forget the immunosuppressed group, whether they've been on long-term chemotherapy and long-term steroid use for other rheumatologic diseases, or any of the monoclonal antibody therapies that are now coming into use for other coexisting diseases.
So is this the typical, epidemiological pattern of patients you're seeing at your ICU?
Yes.
And what about the younger guys? Do they present in the same similar way? And is there anything else that's actually tipping them off into a severe disease? Is there any other risk factors that you're being identified in the study?
So I think, as far as what we have seen within our ICU, I will give you a couple of examples. For example, the sickest, by far one of the sickest patients that I have worked with is a gentleman with a liver kidney transplant and has been on chronic immunosuppression for his transplanted organs, who was exposed to a very healthy family member who had mild symptoms, and he developed severe ARDS, has now been on invasive mechanical ventilation for about 3-week duration. So that to me tells me that the spectrum of disease is hugely variable as what we have seen. Whereas I have seen younger gentlemen who have come in with absolutely no risk factors whatsoever. They are healthy individuals with having great exercise capacity at baseline, running a marathon, and then they come in with this disease and they're profoundly hypoxic, quite disproportionate to their imaging findings, and they're requiring high flow support or non-invasive support to get through. However, I would like to say that at least within our ICU, the recovery for patients who do not have any comorbidities, and the younger they are, have been recovering a lot better than the people with immunocompromised state or other pre-existing comorbidities.
Kavita, one more question. With regards to ethnicity, especially from UK, we hear a lot of reports that say Indians are more susceptible than the rest of the races. Is this true? Is this what you're actually seeing in the US as well? Because it's a multicultural, multi-ethnicity country. So are you seeing the same presentation as in the UK, or is there something different that's happening?
So I can say this for a fact, that I don't think I've not cared for very many sick Indians who are living in the US. However, we are seeing this as a pattern within the entire country, and multiple case reports have come out saying, immigrants seem to be at a higher risk within the United States. And this encompasses variable ethnicities and people from so many different countries who have immigrated to the United States. And I suspect one of the reasons, and after discussion with many people, this is one of the things that highlights for me has been that, immigrants, we tend to live in closer groups within same housing spaces. So the risk of co-infection and easy transmissibility within a same household becomes higher. And that has definitely been a pattern that we are seeing here at Mayo Clinic, is that we've definitely had multiple groups where family members are all admitted with variable spectrum of disease, where some are severely ill in the ICU with ARDS, and some family members are mildly symptomatic, have come into the emergency room and gotten tested, and then gone home to self-quarantine, but they're self-quarantining in a household of about 8 to 10 people. So, and that has been that's a very normal Indian tradition, right? We all live in multi-generational households, and I suspect some of the risk of transmission is within the close quarters of living.
Is there anything to do with the ACE receptors as well, which the virus uses as its entry point to get into the body? Is there some variability, genetic variability in these ACE receptors?
I know that they are doing studies on that to look at the specific ACE receptors also within that coronavirus structure that I showed you earlier. Although there hasn't been a clear indication of a trend of one way towards the other. Or initially, when the disease was first described, there was a lot of hypothesis on whether patients who are on ACE inhibitors or ARBs are actually at higher risk. But I'm actually unclear if this has been shown to be scientific proof towards this, but definitely an area where there's so much research going on because there's so much not yet defined or known about this disease. Yeah, great.